I'd like to welcome our presenters today. We have Rena Muhammad, the Director of Outcomes Improvement with the Social Services Administration with Maryland Department of Human Resources, and also Suzette Tucker with us, Chief of Women's Services with the Maryland Behavioral Health Administration. Welcome.
Thanks, everybody. This is Rena Muhammad from SSA, and now the Maryland Department of Human Services. We changed our name as of July 1. So I'm sure we're all getting used to remembering our name change. I want to thank everybody for coming today. I want to thank our presenters who are going to talk to us about the SAFER model, and I just wanted to give a little bit of context in terms of for SSA, kind of how we got here. We have been working over the past several months looking at a number of different models and approaches related to working with parental substance use disorders and substance-exposed newborns. And so many of you have been on some of our other webinars with some of the other evidence-based practices we have looked at. And so this is our kind of third conversation with developers about a particular model that we are considering implementing as we move forward. This is an issue that I think most agencies across the state are being touched by in some way, and we are really looking to figure out how we can better collaborate, partner, offer a set of services and supports that meet the needs of the children, families, and adults that we serve. So I'm very excited about this opportunity today. I encourage you all to listen, ask questions using the chat box, and really look to help guide us in some of our decision making and how we move forward. I'm going to turn it over to Suzette Tucker and let her kind of give her welcomes from Behavioral Health Administration, who's been partnering with us on this effort as well. Suzette?
Hi, everybody. Thank you, Rena. Glad to be here. I just want to welcome you to this webinar. We're really excited about it. A change, too, for the Maryland Behavioral Health Administration, which is now under the Maryland Department of Health. We have changed our name as well. Everything happened July 1st, so we all are getting used to name changes. And my title has even changed to Director of Gender-Specific Services. So now all the changes are done, but I'm still Suzette Tucker, so glad to be here. Yeah, I wanted just to share a little bit with you about what we're doing here at the Behavioral Health Administration in reference to dealing with pregnant women and women with dependent children who have substance use disorder and are involved in the child welfare system. One of the things that we have gone through or going through is the Policy Academy. So the Policy Academy, we participated in the Policy Academy, back in February to help us understand the needs of pregnant women and women with children who are in the child welfare system and also have substance use and mental health issues or behavioral health issues. We've been going through a process recently where we are actually doing surveys to hospitals. We're doing surveys through DSS, and we're doing surveys through substance use disorder programs to see what are their attitudes towards women who come in for treatment services, who come in to be served, what are their attitudes towards these women, and how do they preference these women when they come in who have these different issues. So this information that we'll get from these surveys will be very useful to us to see what we need to do in reference to educating the field, educating providers. How can we collaborate more with providers to help them understand the needs of the women, and how can we work better with Department of Human Resources as well as our public health entities. So this is an exciting time to deal with this population, and we're so happy that we're here to really move this subject that is so vital to our state forward. With the heroin epidemic, the opioid epidemic in the state and throughout the country, we really need to hone in on what services these women really need and how can we better become a safety net for these individuals. So again, welcome. Thank you for all the work that DHR has been doing in reference to this, and I look forward to this webinar and up-and-coming events that we will have in reference to supporting the women. And I'll now turn it over to Nancy Young.
Thank you so much, Suzette and Rena. We appreciate very much the invitation to share some information with the folks in Maryland today. You see, I have listed the email address for the National Center on Substance Abuse and Child Welfare, and we would encourage all of you to be in touch with us if you have questions and follow-up or looking for additional information or technical assistance on some of these issues. I want to start by saying that the National Center on Substance Abuse and Child Welfare is coming to the close of its 15th year. We have been honored to be the contractor to the Substance Abuse and Mental Health Service Administration and the Administration on Children, Youth, and Families, who fund the National Center on Substance Abuse and Child Welfare for those 15 years. Again, you see the email address as well as the website for the National Center. So if you haven't had an opportunity to visit the website of the National Center on Substance Abuse and Child Welfare, again, I would encourage you to do that in follow-up. So a few topics that we want to go over today. I'm going to start with a little bit of data, talk about what we have learned about what works with families in child welfare that have a parent with a substance use disorder. And then, as Rena mentioned, the screening and assessment and for family engagement, retention, and recovery model and the approach of how we engage families in this change process. And then some of the resources that are available, and even included a few little next steps for you, and then we'll have an opportunity for some questions and answers that you've submitted through the chat box. Well, let's get started. Some data. Of all the children in care, parental alcohol or drug use as a contributing factor has been increasing. When we look at those data in Maryland, it's a very interesting pattern. These are optional items in your state child welfare data system that allows a caseworker or an investigator to check a box if parental alcohol or drugs was a contributing factor for the reason for removal. And this is sort of the static population of all kids who were in care at some point during the fiscal year. I will be honest, I have not been to a state that I've seen this pattern before. And I think that it's probably some things that are going on in practice and perhaps in policy that have some opportunities to look at that. Because when we look at the kids who are entering care, we see a somewhat similar pattern that Maryland is below the national average, but I think more importantly, you may be able to point to perhaps practice or policy changes that happened in 2008, 2009, 2010 that perhaps shifted that trajectory of what we look at over time for these particular indicators. Now, we recognize that there are many reasons that children come into out-of-home care, and these are factors that are associated with the case, not necessarily the way in which Maryland records abuse, neglect, or other kinds of the allegations that are going forward for the rationale and the allegations about why a child is being placed in care. So there are many other factors we recognize that may be associated with this. But again, we haven't really seen this pattern before of going actually down in terms of the prevalence. And I will say that we'll get to, we don't really think that that's actual prevalence. We think that there are some other changes. But when we look nationally of those children who have their parental rights terminated, parents' alcohol or drug use is the second most frequent mentioned reason that they were removed or reason that was associated with the removal second only to neglect, and we understand, as you do, that neglect is often the overarching factor that would be recorded, or the reason that was named in the petitions that may not necessarily have gotten into the database about some of these other factors that may be associated with the child's removal. So 39% nationally. In Maryland, that's almost half. So half of the children, well, not a huge number, just over 400 in 2015, but about half of those children had the box checked that said parents had an alcohol or drug problem. So clearly there are some things going on with how parents get services, how they are able to access recovery, and we think very timely to look at these processes again in Maryland to see if we can tease out some of those underlying barriers that families might be encountering. One more piece of data or so. When we look at the national average, so across all of the states, you saw that it was about 34% in the average. But the variation from state to state is immense, from about 10%, in fact, some of the larger states, California and Illinois, to the highest in Alaska and Texas, Oregon, Utah, and Maine. Now, when I say that we think that it's not just the prevalence issues, we'll get to that again. I don't want you to think that all the drug use is happening out there in Texas, and in fact I know that you are very aware of the impact that it is having in Maryland, and particularly the Northeast corridor. So this is a little messy. These data, the blue line, is if the child was under the age of 1. And again, those same indicators. Was this a parent with an alcohol or drug problem? And if the child was under 1 when they entered out-of-home care, again, almost half, 47% in Maryland, had that box check that said parents had an alcohol or drug problem, whereas all kids age 2 and older, it was about 23%. So when we hear in the national media, there's a very big impact with infants coming into out-of-home care, and it's often associated with prenatal substance exposure. These data bear that out in some ways to look at the under 1 versus older child that's entering care. But the good news is, over that last 15 years, there have been several investments that the federal government has made to try and understand what works for this set of families. And we think we have some idea about what those grant programs put together, what communities and states across the country have experimented with to understand what needs to go into play to make those outcomes look better, particularly the termination of parental rights and some of the reentry to out-of-home care rates that we see in some states. So we've boiled that down to 7 key ingredients, and these data about the 7 came from a grant program that was conducted by Children's Bureau called the Regional Partnership Grants, and then supplemented with also looking at what the grantees did in a set of 12 family treatment courts that were funded by SAMHSA. And those family treatment courts were asked to look specifically at improving their parenting, their child-parent connections, and the interventions for children that they receive if their parent was also participating in the family drug court. So what are those 7? First of all, there's some way of identifying the families. So when we look at those data about the SACWIS data that have about 34% overall of the prevalence rate, we often hear that's not so accurate in most places around the country, but there's some way in these jurisdictions that they have worked on these issues, that they have a system of identifying families. and they have rearranged access in some way to make sure that there's timely access to assessment and treatment. These models might look like a substance abuse assessor who's at the child welfare office or at the family court, a way in which that timely access to an assessment and timely access to treatment is put in place so that families that are identified with a substance use disorder get access to treatment. The third key ingredient is some system, again, of increasing the way in which case management of recovery services and the monitoring of compliance with treatment happens. Again, this may look like a substance abuse counselor who is paired with a child welfare worker. Sometimes it's like in Massachusetts, it's a substance abuse counselor, a DV advocate, a mental health therapist who is available to each unit of investigators and child welfare workers so that they have access to increase that management of access to the treatment resources. And then often that position, not the Massachusetts model that I'm speaking about, but in many of the jurisdictions, they have worked out their communication protocol so that that person who is the recovery manager, recovery coach, substance abuse specialist, they have different names, different models, that is a person who is giving information back in a protocol that's established to say, this is how Sally is doing in treatment on a regular reporting basis so that the compliance is understood very early on in the case and in an ongoing monitoring kind of system. We also know that reunification rates and very low reentry to out-of-home care rates were associated with having services that started right away to engage families in improving their parent-child relationships, understanding appropriate parenting practices, and that those services were delivered in a family-centered approach so that each of the individuals in the family were identified their needs and the services. And then in many of these jurisdictions, there's some way in which the court is involved to increase the judicial oversight. Many of you are very familiar with family treatment court models. There are a few jurisdictions in the country that have increased that kind of administrative review. For example, Connecticut doesn't have family treatment courts, but they do more frequent reviews and administrative reviews with the family and with a retired judicial officer so that prior to the child being removed, there is more frequent oversight, and also after, if there's a child that's removed, that they're not waiting the typical 6 months for the case to come back up in court, but that there's some increased judicial oversight of the case. And along with that, based on evidence-based practice of contingency management, a systematic response for participants for understanding the things that they have been able to do, understand the barriers, and to have a systematic response for participants when they are not compliant with the treatment program or other aspects of participating in self-help or the drug testing protocol, the other kinds of things that we typically see in a substance abuse treatment case plan. So some systematic response that's understood by the parent's attorney, by the child's attorney, and by the parent, and by the family members, and by child welfare and the treatment agency to have agreed upon. This is our systematic response, again, based on evidence-based practice of contingency management. And then a collaborative approach, which encompasses many areas of both the non-adversarial approach that you see in a family treatment court, as well as a way to ensure the effective communication across systems, the staff training, the way in which information is shared, that there is a collaborative approach to how these connections happen across the system that reduces the noise and increases the communication. And that's part of that SAFER model that we're going to get to. So those 7 key things, we know that in jurisdictions that have put these aspects together, again, they have been able to document in their CFSR outcomes, the performance measures of child welfare, as well as looking at recovery in terms of parents' participation in treatment, completion of treatment, reduced substance use, and then these other, the R's, if you will, the 5 R's that we focus on, and try and help communities understand where to get the data, how to keep a scorecard of the data and monitor the data so that the children that are able to remain at home, the reunification rates among families with substance use disorders, as well as the repeat maltreatment or reoccurrence of maltreatment, and the reentry into out-of-home care. So the 7 key ingredients and the 5 R's, we think those are very important for communities to understand and to have a way in which they're monitoring those in their counties and in their communities for this particular set of families who are at, the data would say, very high risk of not reunifying or perhaps coming back into care. So what are those key processes to implement those 7? So how are families identified, assessed, and referred? How are families supported in that referral process to actually engage in treatment and to have services delivered? And then how are cases and outcomes monitored? What's the feedback loop for the macro level of the community as well as for individual cases so that there is a feedback loop of understanding how families are doing and what next steps of action in the case plan needs to be both in the substance use disorder and mental health treatment case plan as well as in the child welfare case plan. So we're going to talk a little bit about then this early identification, assessment, and timely access to treatment. Very early on, we started getting lots of questions about how do we improve our screening and engagement, and we'll talk a bit about that, but it occurred to us that when we're talking about sort of standard services about where early identification or where identification of a family affected by a substance use or mental health disorder actually happens, looks something like this in most states. Now, you may have different names for some of these processes, but after the hotline, there's a risk and safety assessment, and often, hopefully, there's also an alcohol and drug screening, so AOD, alcohol and other drugs, screening and assessment that feeds into that hearing. This is when a child has then been removed to either the 72-hour hearing, emergency hearing, again, different words, detention or shelter care hearing, that then goes through the case plan and adjudication hearing and disposition. So after the investigation and development of the case plan, and then into the court process of a periodic review hearing. And what we learned early on is that this is typically in most jurisdictions across the country where a referral to treatment happens. That is sometimes 30 days, sometimes 45 days, sometimes 90 days. But we also know that the point of intervention for supporting that timely referral to treatment clinically only makes sense at the point in which the parent, the mother and the father are going through literally this crisis. Who is there to help them as they're going through this crisis of the shame and guilt and loss of hearing that their children are going to be retained in out-of-home care and that there will be a hearing in 48 hours, 72 hours that they should appear at to find out what their next step is. What happens at that very first hearing that is focused on engaging parents? Is it a case plan or a list of phone numbers? I often tell the story of some 22 years ago now when my husband and I actually became foster parents, and our birth mother on a Friday afternoon said to the caseworker as she was coming to grips with the fact that her children were going to stay at the emergency shelter and there would be a home study to see if the children could come to our house. This was an extended relative of mine, and she was grappling with that awareness and shame and grief and loss, and she said on this Friday afternoon, a heroin IV drug user, I know I need to go to treatment. Can you help me? And the social worker said, I don't have my list of resources with me today, and I'm off on Monday. Call me Tuesday. Now, I know that that was 20-some years ago, and that practice has changed dramatically since then. I fear that there are many communities in which that would still be seen as an effort that said it met the requirements of the Adoption and Safe Families Act of reasonable efforts. But I can imagine that those of you on the phone, we could take a poll and say, how many of you think that she called on Tuesday? And so part of this effort is understanding both clinically what's happening to this family, what's happening in the brain science of addiction that we understand at that moment, which might be a more effective point in time to support that parent's engagement in treatment. Now, do I think that's the panacea and that's going to work for everyone? No. But if we don't try to look at what's reasonable from a clinical standpoint of a severe substance use disorder and think we can wait 60 days and make a referral to treatment, or sometimes longer than 60 days, if the coping skill that you've been using since your early teens has been to anesthetize yourself from emotions and pain by using some other substance outside of yourself, what do you think is happening between that 30, 60, and 90 days? I think we know better than that, and our effort is about the compliance with the things that we make available to families, but also making sure that our system is working for families. So this idea of early engagement and the way in which we try and get early access was tested out in the state of Illinois. And this is a randomized control trial from their 4E waiver. Many of you may be very familiar with that, that have been participating in the Maryland waiver. They just published this in the current issue of the Journal of Substance Abuse Treatment. And they said, would this effort of comprehensive screening and assessment plus early access to treatment produce positive outcomes? And what they found was that it did not, unless they had this other ingredient of, in Illinois, they call them a recovery coach. So that idea back up there on the 7 key ingredients of some method of managing the access to treatment, of managing the access for parents to get into the services that they need, happens in Illinois through this recovery coach program. But we think this is very, very important data. They're important findings for all of us in the country to look at and say, what's reasonable with the way in which we are doing reasonable efforts for families that have severe substance use disorders. Now, it could be that you say, well, there are a lot of things about the way in which we look at these families, and you know, we do an effective referral, and they don't comply, they don't go. There are too many other things that happen that keep them from accessing services. And I often will ask folks to think about individuals with a brain injury. We know now about the neurochemistry of addiction. If we think about these individuals in early abstinence at best, not recovery, if we think about them as someone who has had the reward pathway of the center of their brain hijacked by chemicals outside of their body, and they in fact have a malfunctioning brain, they're not accessing their frontal lobe for good decision making. We know this now about the brain science of addiction. What would it take if we had somebody that had, say, a severe head trauma? Would we do the same kind of practice and call it reasonable effort, or would we change the way in which we put services together to engage that person in treatment? So how do we do all that? How do we make all this happen? How do we look at our systems and say, are these reasonable expectations of families with a severe substance use disorder? Very early on, when the National Center on Substance Abuse and Child Welfare was developed, we got a lot of questions about, it often sounded like this: just give me the screening tool that I can add 3 or 4, maybe 5 questions at the most to our intake protocol to understand if this person has a substance use disorder. And in fact, there are many jurisdictions who have put in place a universal screen, because we found over time, when we look at these models about screening and assessment and why there are data that look like that variation from state to state that you saw previously, there are at least 2 common ways in which we look at these barriers: that there is not a standardized screening and assessment protocol. So worker to worker, county to county, state to state, it all varies. And then secondly, there's not clarity in the information system about where and how to record the results of that screening and assessment. So if you were going to a state legislature and you said, we're being impacted by opioids in our state dramatically, it's driving infants going into out-of-home care. In Maryland, you might be able to say that. Half of the infants that were placed in out-of-home care had the box checked. But then they say, overall, what's that impact mean across your state? Well, less than 30% of parents have substance use that's associated with the child's removal. There may be other priorities for your state legislature than trying to address that 30% or the smaller population. Now, I've been told, and I think that it might have some validity, that perhaps those percentages are a bit higher in Maryland than what is being recorded. So thinking about the way that we assess screening and assessment protocols, thinking about those 2 different aspects: the screening and assessment protocol at the worker level, and then the information system about how we're recording it. So early on, as I mentioned, we got a lot of, just give me the 3 or 5 questions. It was like everyone wanted the silver bullet. Now, you may recall that was coming out of the cocaine epidemic and edging into the methamphetamine epidemic about 15 years ago. And so there was a lot of requests about what's the screening tool we should use. And what we found when we sat down with a group of professionals to actually look at the technical assistance monograph that you see, the cover on the screen, SAFER, what we found is that when we began to really talk about this, that it really is the team of who is doing the assessments and not the tool, that it was much more important to have the team of individuals who have the expertise in substance use disorders, as well as the Child Protective Service system, to be working together in the team. And it really didn't matter so much about which tool they were using, but that the communication between them and the teaming was very important. And then we get a lot about, okay, and so then what do we do? How do we respond to these cases? And our answer back may be a little overwhelming, because it would be nice if we could just say, you know, do these 7 things and everything's going to just be hunky-dory. But as soon as you look at those 7 key ingredients, you know that there's no single agency that can do this alone, and that treatment agencies and child welfare agencies and the family court and the mental health agencies and domestic violence and housing are all key ingredients that we need to be able to partner with to understand what they bring to the table and to understand how we can work together in a way that really addresses the service need as well as the communication need, because as you all know, it is not a one-time thing. It is not a discrete package that says, aha, in the first investigation before the shelter hearing, the detention hearing, in that first 72 hours, we knew everything that was going on and we were able to write a case plan. No, we often hear back that some of the reasons that states tell us that their data in those SACWIS data are low is that you don't recognize perhaps until well into the case that what's really going on underneath there is a substance use disorder that wasn't detected in the first 30 or 60 days, and that it requires this ongoing assessment to understand that. So when we talk about screening and assessment for family engagement, retention, and recovery, we recognize that it's an ongoing process with clear communication paths. And I'm going to spend a little bit of time on the communication path in a minute, but I want to tell a story about a state I was in, and this was actually even before the National Center was funded, so the very early 2000s, and they had a remarkable system that a child welfare worker could call an 800 number, and within a very short window, usually 48 to 72 hours, there was an agency that was contracted to provide an assessment within the 72, 48 hours and give information back to the child welfare worker about the results of the substance abuse assessment. And we're in this state level meeting, and the child welfare director is there, and the director of the substance abuse and mental health agency is there, and the contractor that is providing the assessment was in the meeting. And the child welfare director says, you know, this system is just not working. We send parents, sometimes moms with 3, 4, 5 sometimes prenatally exposed infants, that we send over to get an assessment, and you send back information that says no treatment recommended. What is up with that? And the agency that was doing the assessment said, well, did you tell us it was the 3rd prenatally exposed infant? And it was as if light bulbs went on immediately in that room, that the idea that assessment is both ongoing and that it takes working out the communication of what the child welfare agency already has knowledge of in working with a family, and does that get transmitted to the individuals that are responsible for doing that assessment. So what they were able to work out is actually that the petition was also able to be released to the substance abuse assessor agency so that they could use that clinically. They could say, you know, Sally, I understand you say, you know, you never use drugs and this is just all malarkey that's in this petition. I understand that, but, you know, here, this is what went to the court, and now this is your opportunity to be able to document your case that this is not so. And it empowers that mom to be able to say, aha, I get a voice. It's not what somebody else is writing about me, but now I get a way in which this assessment and the ongoing monitoring of what I'm doing in treatment is able to be carried over in a communication to child welfare and the court. So a very different way of looking at what is the assessment for. If the exchange of information is to engage families in services, the models look different, the programs look different. So when we say assessment happens throughout the life of the case, when we sat down with this group of 30 or so professionals to say, help us understand screening and assessment, that what they determined is that there are a set of key actions that happen in child welfare practice and in substance use disorder treatment that are common kinds of assessment questions. So both in treatment and in child welfare, they're asking this question: is there an issue? And if there is an issue, what's the immediacy of the issue? Now, in today's world of opioids, that immediacy might be, is there a threat of overdose death? What's the immediacy that the substance abuse treatment agency needs to respond to right away? Or is the immediacy of the issue in child welfare that there are profound safety factors that are not ameliorated with enough protective factors that this is an immediate safety issue that we have to act now? So the first thing that both agencies are understanding, is there an issue, and what's the immediacy of that issue? And then second, moving into sort of that assessment phase. So if it's an issue, substance use disorder, child abuse, or neglect, what's the nature of the issue? And what's the extent of the issue? And then finally, how do you develop the case plans? How do you monitor change? How do you prepare for transition and the outcomes of treatment? And how do you understand if those interventions worked? So those three categories, if you will, are sort of the foundation of what's in SAFER, of helping communities understand what happens now. This isn't like, let's come in with a new assessment tool that is going to be loaded on top of what child welfare is doing right now, or let's have this new way in which the substance abuse treatment agency is going to do their practice. But first, let's understand the way these processes work in the right now, and then perhaps we could look at, is it sufficient? Are there gaps? Do we need to have a standard protocol for screening that isn't in place right now in my community? Is there a way in which we need to establish communication between the systems that needs to have a standard protocol? So the first thing that SAFER would say is understand your current system. And part of that is understanding the definitions of terms and these processes. So I'm not proposing that in all the communities or even statewide in Maryland that these are the right kinds of terms. But there's some way in which alcohol and drug services are screening to understand if this is a substance use disorder. And there's some way in which the child abuse agency is screening to understand if in fact there's a child abuse or neglect situation. And we can run through each of these so you recall those questions that underpinned each of those three aspects. Is there an issue? What's the immediacy? What's the nature and extent? In substance abuse treatment, that would be making a diagnosis. What's the extent of the issue? A full multidimensional assessment in substance use treatment to understand all of the treatment needs. In child welfare services, a family assessment to understand the treatment and the case plan needs of the family. In other words, these are things that are going on already in your counties and in your state. And again, I don't suggest that these are the right terms for your community or Maryland, but there are processes that need to be understood now in the community, and then the assessment of, is it working? Does it work to have the screening happen the way it does right now? Your data that are entered in the SACWIS system would suggest maybe not. Maybe it's not working so well that we don't have a universal screening tool, or perhaps it's that method of getting it into the data system, or maybe it's the way in which the handoff happens from being able to give the parent a list of phone numbers for referral and unassisted that doesn't work. So understanding, and the SAFER monograph gives you some tools about how to ask the questions and get the information across the system so that you can begin to map how is a family supposed to get from A to B. In my birth mom's case, she was supposed to go home on Friday afternoon and make a phone call on Tuesday. Now, again, met the letter of the law of reasonable efforts. No one asked if that was reasonable efforts when her parental rights were terminated. But did it really make sense for her on a Friday afternoon to not have the hope that can be delivered at that moment to say, there is a way that you can do this. There is a way that we can get through this. So from that assessment information, there has to be a way of communicating that. Again, as I said previously, that reduces the noise and increases effective communication, because I don't know how many communities I've been to. We actually have a little test. I'll tell you, I'll let you in on our secret, and you can do this in your community. If you're engaging with child welfare and substance abuse treatment and your court professionals and trying to work out some of these early kinds of issues, sometimes we say, well, how long does it take for confidentiality to be the reason that there's a barrier that we can't do this? Because confidentiality, we have found, is not the barrier that prevents effective communication. It is a way in which you can understand what is protected information and how to engage families in the way in which this information is communicated. So how long is it going to take in your community for somebody to say, we can't do that because of confidentiality? And that's a marker of the trust. It's the marker of how much collaboration there has been in the past, and a way for you to really identify a barrier that needs to be worked through about how that is going to happen. And we talk about that in terms of, you're not sharing everything that the treatment agency may know about the parent. When it comes to safety and risk factors for the child, that's child welfare's job. You probably, however, need to know if there are changes in the treatment of Sally coming to treatment or disappearing, or one I hear frequently is an unrelated male has moved into the house with Sally. That's a risk factor that child welfare wants to know, and you need to know that pretty quickly. So working out those protocols of who needs to know what when. Is it information that needs to go from the petition to the court to the assessor, or from the assessor back to child welfare, and then from the treatment agency to child welfare, the parent's attorney, the child's attorney, and the other players in the life of this case? So who needs to know what when? Okay, now I'm going to put a slide up, and it's going to look totally overwhelming. So just bear with me for a minute. We're going to walk through it. This is a model of the communication bridges, and it is a way in which you can look at those three components: presence and immediacy, nature and extent, and monitoring the change, the transitions, and outcomes. And we are going to give you some suggestions about perhaps these are the kind of information that needs to be transmitted for you to have a leg up to say, yeah, this is what we need to know. So you see the four primary boxes of what the Substance Use Disorder Treatment Agency shares with and whom, and then vice versa. So let me run through this for a minute. You'll have this PowerPoint, so you can get into the guts of it when you have time to read all of that detail and say, you know, does this make sense at all? This next slide is maybe more overwhelming than this one, and how much is on there. But I want you to focus just here for a minute. So what this says is an example of the communication bridges, and it says for the Substance Use Disorder Treatment Agency, they need information from child welfare in that red circle. What's happening, the reason for the assessment, the results of the investigation, the family's history with child welfare. Is there already a child welfare case plan? In other words, in-home services, out-of-home services. The person at the substance abuse treatment agency would be really ahead of the game if they had this information. And then, secondly, in the lower part of that box, what is it that they need to share back to child welfare? So again, this is a bit detailed, but we're hoping that providing this, and we have it in a Adobe fillable format so that you can go through this template and say, well, we need to add to that some more specification about what the safety factors are if the child is in-home services. We want more detail there. Great. Detail it, put it into your protocol, add that to your protocol so that there's understanding across the agencies. So not just one of these very complicated charts, but here's another one that's for child welfare and examples of what they need to share with the treatment agencies and the court and other support agencies in the community, and then the court and what the information they need and what they need to share, and then finally other community agencies of what they need and what they need to share. So I know I didn't do any of that real nitty-gritty detail. That's for you to do because we're giving you the hints. We want you to say yay, nay, or add. Yeah, that looks like the right thing that we need to share. No, this is like too much detail. We can't possibly do that. Or we need to add something that's really important in Maryland that we haven't thought of to put in as an example. So these are templates for you to be able to look at with your partners and say, how are we going to communicate this information? Just a couple more points before we go to questions. And the first is about rethinking engagement. This is work that has happened in the substance abuse treatment world over the last decade plus about understanding what does it mean to look at effective engagement. And we think that there's a systematic approach that says that we're focused on the barriers, we're doing this in a partnership of a collaborative, we're focused on enhancing motivation, evidence-based practice that I think many are very, very familiar with now, and that it is family-focused. It's not just about the parent, it's not just about the child, it's about how we understand the needs, the strengths, and the challenges of the family together. So these principles of effective engagement means that we need to look at the barriers. Again, this is a lot of detail. I don't expect that you're going to catch all of that in this session today, but we would encourage you to be in touch to be able to say, you know, these are the kinds of organizational barriers that exist in communities, the interpersonal ones as well as in the environmental ones, and then what are some suggested strategies about how you can make some changes in each of those three areas of barriers and proposed solutions, if you will, and how you provide those solutions and do some plan, do, study, acts of did this work? Did this increase engagement? Did this increase treatment completion? Did this increase the way in which we were able to get parents working their case plan? Were we able to shrink that time from the very first contact with the family to treatment entry? Are we monitoring that in a way that we have a dashboard that says, we're looking at this? Now, I couldn't help myself with this because sometimes we hear this. Well, I've actually heard, well, the substance abuse program, we have drug testing. I just want to reiterate that drug testing is not treatment. It may very well be a very appropriate adjunct to a treatment program. It may very well be something that is worked out in that monitoring of case plans that we need to be focused on. But drug testing is often used as assessment, and it is not a substance use disorder assessment. It says this particular person used this particular substance that produced metabolites in their body fluid within this window. that doesn't tell you anything about what level of care this individual needs. It actually tells you, gotcha. It actually tells you we were able to find you. It doesn't say this is about engaging your family in a change process that allows your family to heal and allows you to be able to parent your children. So no single agency can do all of this. We have a variety of materials about collaborative capacity, the governance structure, and the leadership. I'm just going to focus on that governance structure to begin with because I think that that may be very important for some of the conversations that you're having at your local level. So why is it so important? Obviously, the broad representation of who has the seat at the table, making sure that we're getting all of those critical functions at the table, and it increases the ability to sustain this lasting change. The governance structure, when a state or a community asks us to work with them, is one of the first things that we want to be able to assess and to make perhaps changes if they don't have a governance structure that's going to allow these policy and practice changes to be sustained over time. So what we mean by those critical components is we think it's a three-tiered structure. You'll hear and read a lot about this in the SAFER monograph, and you see the other components that are necessary for the governance and leadership of defining the mission, understanding what the structure of the meetings is, when the key players start sending other staff to know that that's a marker of some problems in the leadership and in the governance. How do you have those markers to say we've got a strong, effective collaborative, not a bunch of people sitting around a table? Because we have all been to collaborative meetings that go on and on and on, and there never seems to be much beyond sharing information. If all you're doing is sharing information, it's not an effective collaborative, because an effective collaborative has these various levels of who's in that membership of the Oversight Executive Committee, who's in the Steering Committee, and who's in that case level team. And each of those different committees, each of those different components of the collaborative have their own roles and responsibilities. You see some of that in terms of the primary function, that the case level team understands best what's happening with families. They're focused on outcomes, and they're very focused on understanding what the barriers are. What are the challenges? They're meeting fairly frequently. These might be family group decision-making kinds of teams that are bringing the Substance Abuse Treatment Agency and other community partners into that, so that there's a way in which staff are looking at and collaborating at the case level with clinicians and child welfare workers to understand what's happening with individual cases, with the idea that they're really trying to identify what are those common barriers that families might be experiencing. And then a steering committee, and you see management level. These are the folks that can take those barriers and either remove them or take them to the oversight committee that says, this is the way that we can get rid of these barriers or understand what needs to happen to remove those barriers. So they're management level staff in the agencies that have their own collaborative effort. We suggest some things that are standing agenda items to get you away from sharing information, that you're looking at your data, you're identifying, you're taking the barriers that were identified by your case level staff. You're looking at the funding and sustainability and how can this be put into place to be able to be sustained. You're understanding what the staff training and knowledge development needs are, and you're reaching out to the other community agencies and collaborative partners that need to happen. So we would suggest to get away from, we sometimes refer to that as a BOGSAT, a bunch of guys and gals sitting around a table. And if you're in a BOGSAT, try these standing agenda items of how you're going to look at data and monitor data and these other 5 agenda items to get away from how we're just exchanging information over and over, month to month or quarter to quarter, and really get into the really nitty-gritty of understanding collaborative practice and what needs to happen. And then we have found over the years, over and over again, if there is not an engaged executive committee, that the efforts tend to die over time. That the only way to ensure long-term sustainability is that you have not just the blessing of the executive committee, but that you have their commitment to understand the barriers that haven't been able to be resolved. They're monitoring data and understanding what are the practice and policy changes that need to be made and how they are ensuring implementation at the director level across agencies. Some of those things that are the warning signs, I mentioned one already, but the other ways to know that you have a weak governance structure is there's a lot of stepping on toes and hurt feelings and duplication of work because no one has sat down and really said, whose role and responsibility is it to do that screening tool? Whose job is it? Whose responsibility is it to get it into the SACWA system? Whose job is it to make sure that the substance abuse assessor has the information that they need? Whose job is it to do that assessment and communicate the results, and what time do they need, and how quickly can that happen? So understanding the clarity of roles and responsibility is part of that steering committee to actually specify those. It reduces the noise between the system and says this is what our collaborative is built on. This is the real work of collaboration. So those warning signs are very important. I want to spend just a minute to run through some of the resources that are available to you. I mentioned that we're winding up our 15th year, and so we have produced a lot of publications and online resources. You see a smattering of some of those about data systems. The most recent, up in the left-hand corner, is about a collaborative approach to treatment of pregnant women with opioid use disorders. The one in the middle, the substance abuse specialist, what are the different models about how that recovery management is put in place with child welfare. So lots of different publications and resources that are online. Did I mention our website? I know I did. I really want to encourage you to visit the website to get some of these resources. And again, this is one of the top downloaded resources for child welfare is some basics. It's like a basic primer on substance use disorders. It's meant to be sort of a desk guide, and you can download copies for the frontline workers in your office. And then I already mentioned the specialist monograph that looked at 6 different states that had different models of recovery management in place. Also the drug testing monograph about how you can effectively use drug testing, particularly in engaging families. And then if you're not familiar, there are 3 online tutorials geared to 3 different audiences. The first one to child welfare, understanding substance use and facilitating recovery. That has about 8 states that require that course to be taken by all child welfare workers. It comes with free CEUs from NASW. The second one is geared to substance abuse treatment professionals about understanding child welfare. If you have an agency that you work with as your substance abuse treatment provider, it helps a lot if they understand what's happening in those timelines, what the court does, what the different components of child welfare do, and how to engage with them. And then finally, the guide for legal professionals. The online tutorials were revised last summer to increase the information on family treatment courts as well as opioid use disorders. So if you have a training need of your child welfare workers, I would encourage you to look at this online training. It's about 4 hours. You can start and stop and come back to where you were and get free CEUs at the end. And we have about 70,000 people in the country who have taken these courses. So it's been well received. And then visit the website to get a copy of the monograph. And now the work. What are we going to leave you with? Did I mention visit the website? I'm kind of teasing now, but there are a lot of resources there, and I'm always a little bit surprised when I go and ask folks in the audience, have you been to the National Center website? And despite the numbers that we track, there are an awful lot of people that are not familiar that there are a lot of resources on this topic as well as a host of others. The second is a little bit perhaps more challenging. If you have not gone to lunch, if you are in child welfare and you have not gone to lunch with the director of the treatment agencies in your community, that's one of your assignments. Go meet them. Take a tour of the agency. Understand what they do. Understand what their challenges are, and vice versa. If you're in a substance use disorder treatment agency and you don't know the supervisors and the program managers or the administrator of your local child welfare agency, call them up. Call them up. Start having regular contact that says, how do we begin to partner together in a way that's more effective for families? Determine if there's already a table in your community. Some of you have perinatal councils for many years. Is that the right table to have these collaborative discussions with, to do this assessment, to do a walkthrough and say, how's it working for our families? The fourth, ask for help. You can contact us. You can contact your state agency. They're very interested to know if these are ideas that you'd like to be involved with in terms of really building real collaborative practice at the local level. And I know that they would be very anxious to hear that, yes, we'd like to have some help about how we're going to do this. And then, you know, one of those first tasks is sort of that walkthrough. How does the system work now? Do families get a list of phone numbers and say, you're on your own? Is there something else that's in place that's working? Is it need to be focused on how much time it takes to get it to work? Identify how the system works now is one of those very first assignments so that you can parcel out what are the strengths and what are the challenges. With that, let me ask if there are any questions that have come in over the chat box, and I'm told no, there aren't any questions. I don't know, Rena or Suzette, if there are any questions that might come to mind for you for discussion.
Thank you, Nancy. I think Suzette had to jump off for another meeting, so I'm not sure she's still on the line. I don't know if there's any specific questions that come to mind specifically as I think about this. I mean, I think it's exciting, and I think it's definitely the direction we need to be thinking about. I guess as we kind of process everything that we heard, the question is how. If we agree this is the right fit in the right direction, then what do we need to be doing at this point? And for me, the question I would ask my local departments is, what role do you see the state playing? What support do you need from the state if we decide this is something that we want to continue to pursue? And that's not necessarily a question to answer today, but it would be one of the things I would like to get feedback on.
Terrific. And I know you're in communication with the locals and your offices frequently, but is there anything I know that you also have some statewide initiatives going on. Is there anything that's going on in the statewide initiatives that opens this opportunity that the local jurisdictions could be involved in, or giving you some feedback about some of the effort that they have underway or ways in which they'd like to be engaged?
Mm-hmm. Yeah, so I think, there's a couple of things. We have we're part of the 3 Branches Institute with 7 other states. which brings together the three branches of government to really work on an issue. And this is one of the things that group has been tackling. And we've had the participation of 2 judges in our system, one from St. Mary's County and one from Baltimore County. And so I think, and we have some local departments that are on, sit around that table, and many of our other stakeholders. I think many of those folks are on the call today. I think that's a venue to be able to hear from local departments. So Anne Arundel County, Baltimore County, Baltimore City has, and I'm sure I'm missing folks, so I apologize if I missed you, sit around that table. So for my local departments, that might be a table where you could certainly share some information with us about what's working or what is not working in your community. And we have, like I said, we have involvement not only from legislators, but also part of our judiciary branch. And so that's a great place to really kind of bend the ear of some of our local judges and legislators. And then I think, there's lots of tables that are around, at least in the child welfare side, that provide opportunity for the local departments to share ideas, whether it's through our steering committee or any of our work groups. Those are definite places where we are looking and hoping to get feedback from folks. I know that folks here at SSA are involved in the Policy Academy that Suzette mentioned earlier, and so that could be a place where we build kind of some feedback. And so I think there's a couple different places where not only our local departments, but our stakeholders and our partners are also around the tables, where we can at least begin conversations about what this might look like and what we need to be attending to that maybe we're not attending to right now, or need to grow because we have a part of the state that's doing a piece of the work really, really well. So,
great.
Any other questions come in? I don't know if,
we did get one other question. Sarah, can you read that question for us?
Sure. Does the use of the term recovery in this presentation include both substance abuse treatment and behavioral mental health treatment?
Well, let me back up and say that the SAFER monograph as a technical assistance tool was published in the mid-2000s, and it was one of the first products that was created by the National Center on Substance Abuse and Child Welfare. And our guidance from our federal agencies at that time was to focus on substance use disorder treatment, which of course was called substance abuse at that point, as we've evolved with the DSM. In the back of the monograph, there are screening and assessment tools that are often used in practice, and it does include some mental health screenings and mental health assessment, although it was not the specific focus. And so you keep hearing me say substance abuse, child welfare, and the courts, which was the directive, if you will, for this work that was created. We recognize that in the ensuing years that the definition of recovery has happened from SAMHSA, which wasn't there. No, you won't find that necessarily in the monograph. We tend in this monograph to think about the mental health services as part of those other agencies. We recognize that in many jurisdictions, the publicly funded mental health system directs its resources to the seriously mentally ill population. And often what we find with parents that have a primary substance use disorder, or perhaps secondary to depression, anxiety, some of the other bipolar, perhaps some of the other mental health concerns, that those services are more difficult to access. So I certainly recognize that. And we do know that as the systems have changed, as the knowledge has changed in the last decade in particular, that is important to think about, not just screening for substance use disorders, but also screening for mental health concerns, because they often, as you all know, interfere with a parent's ability to engage in treatment. And that back and forth in the communication has to include the mental health treatment system as well as the substance use disorder treatment. And in Maryland, often those are in the same agencies, whereas in many states they're not. But Maryland has adopted a different approach than many other states. So I know that was a very long-winded answer to say yes, but probably not in the way you're hoping for. You can certainly find it and certainly find information about screening and assessment in the monograph, but it was not the central focus of the preparation of this. Certainly, as we've knowledge gained and evolved over time, we try and always make sure that when communities are coming together to look at these challenges for families, that they're addressing both substance use and mental health. Sarah, another question?
Yeah, we got one more. It says the concern we have is about confidentiality and sharing too much information with other agencies. What is your advice?
Well, first of all is to engage the professionals who are around your table about what they need to know. Often that the Child Welfare Agency doesn't in fact need to know the whole case history of a mom in substance use treatment. They're focused on what are those immediate safety concerns and risk factors that they need to be considering in their case planning. And in fact, it's not a substance use treatment or mental health treatment professional experience or the way in which they do assessments to understand those risk and safety factors. So making sure that there's clear communication about what it is that child welfare and the court needs to know and what is covered in, first of all, your confidentiality agreements with your clients, with parents that you have in your treatment agency, and again, making sure that the routine nature of this is established. There are a variety of communities. For example, the state that I was talking about that said that they didn't have communication that was going from CPS to the assessment. They actually sat down and said, what do we need to know and when do we need to know it? And we're able to put in place a much more of a checklist kind of approach of regular monitoring. But what they got was twice a month, child welfare workers would get from the treatment agency things that are very behavioral, like the parent was supposed to come to X number of sessions and they came to this many. They were to attend this number of self-help groups or peer support groups, and this is how many they did. They were to drug test this many times, and these were the results. They were to meet with their substance abuse caseworker this many times, and this is what they did. So very behavioral, not a lot of interpretive of what does that mean in terms of projecting, is this a family who's safe? Because that's not the training in the background of a substance abuse professional. That's the training in the background of child welfare professionals. And vice versa, working out what the treatment agency needs to know. They can be very frustrated when there's a change in the case plan and says, okay, 3 kids are going to go home next week. And they don't have the opportunity to work with that parent to prepare for that. So that communication about changes in case plans or court dates that are coming up or things that are happening in the child welfare case plan to understand what needs to be communicated. Now, one of the keys, and it may be a little bit more of a heavy lift, one of the keys is that you need the attorneys at the table from the beginning to understand these communication protocols. Parents' attorneys can often be the linchpin in a parent engaging in treatment or not. And the child's attorney can often be the way in which parents can get to treatment and be able to reunify or not. So understanding from the beginning, what's the goal of changing our communication protocol? And what is it that we need to know? And how frequently do we need to know it? You can imagine if you were getting those behavioral indicators twice a month and you were a child welfare worker. At the end of 3 months when you're ready to write a report, or you need to be doing your home visit that month, or the way in which you're engaging with the family, you might have 6 monitoring reports that allows you to say, over time, this is the progress that the parent is making, that it's not a got you the parent used, it's, oh, wow, look at this. There was something that was going on in that parent's life, and at month 4, she lapsed. She went out and used, but she came back and she returned to a pattern of engagement in her treatment program. The reaction of that going out and using, when you have that pattern of behavior established, would be very different than she used, oh, we need to make sure that we go out and pick up the kids. Because that engagement of knowing that there was a drug use and empowering the mom to say, you know, we can report this, you know, when we're reporting it, because we have this protocol that says drug use gets reported in 24 hours. So I'm going to send this over to your caseworker, but what would it be like if we sat down together and called your caseworker and talked about what happened and what your plan is now? That's about engagement. That's not about gotcha. And those are the kinds of things of building the trust over time. I hear frequently, it's not about the information that's going to be exchanged. It's about not trusting what you're going to do with it. And those kinds of relationships and those kinds of trust between workers and between systems comes with having clarity of roles and responsibilities, and the treatment agency meeting their roles and responsibilities, the child welfare agency meeting their roles and responsibilities, and the various attorneys meeting their roles and responsibilities. And once that has been established, then if there's a hiccup, there's trust there to be able to say, hey, this is what was really going on with Sally, and we need to be able to do an intervention. Maybe she's in outpatient and we need to step up to intensive outpatient, or maybe something really went haywire. This isn't a good situation. We need to get Sally into residential treatment. But it's the team that's coming together to say, this is what's going on, because we've built that trust and we've established that pattern of behavior that really establishes the move towards recovery. Anything else? All right. Well, I want to thank you all again very much for your participation today, to Rena and others at the state office for the invitation to share with you today. I want to ask that when will have my contact information when you get the PowerPoint, but also when you sign off, you'll be directed to a very short evaluation that we need to use to monitor our outcomes also. So we would appreciate very much if you would take just a moment, a few minutes, to give us some feedback about the session today. And perhaps more importantly even is to be in touch with us if there's additional information that we might be helpful with. So thank you all very much. Enjoy the rest of your afternoon, and we look forward to hearing from you.
Thank you very much, Nancy. Everybody take care. Have a great day.